the thing, right? Um, so right now there's actually a class going on for a couple of the remedial students. So I will start at 6:10 sharp. Hopefully that gives them time. I mean, we have to start on time today. Rest is a lot. I will start in about three to 4 more minutes. All right. So just bear with me, guys. Afternoon, everyone, and I'll talk to you all when I come back. Okay. All right. Hi. Good day. Good afternoon, everyone. Monday, 17th March. We get another day closer to our final exams. I hope everyone is fine. I hope you all are well rested from the weekend. I know Mondays oftentimes the hardest day to do anything. The week is now starting. But I hope you all have been working hard. I hope you were productive over the weekend. A large majority of you have answered the homework, and so thanks for doing that before, because it kind of makes it a little more tricky for me to be as responsive as we go along to things that you would have done in the past, right? So, guys, make sure anything that we do during the week that you have all the questions, all the homework, everything during that week, right? Because now when I send the homework, I'll probably just forward you the answers and if you ask questions, my replies might be a bit delayed, all right? But thanks to most of you for doing that. Again, I was really, really impressed with the effort that went into it and how serious you all are taking your work. I think definitely once you are studying on your own, studying in your free time, guys, doing questions every single day, you're on the course for not only success, as I say, you're on the course for excellence. So keep up the hard work, keep up the good work. Saturday was surgery. I got some feedback. I think surgery was okay. I'm not a surgeon. I haven't done surgery since internship, and I haven't studied surgery since MBBS. So I think the breast class was kind of impromptu for me because I didn't have like time to go back and study much, but I think it turned out pretty okay. A couple of recommendations were that I use more visual teaching. So concerning the visual teachings in terms of images, it's kind of hard for me to do that all the time, but I will try to include some more images going forward. And that's why I kind of introduce this drawing thing just to kind of get the picture across, right? So that's that. It is imperative to pay attention to everything that I see and every word that I see for various reasons. I can't like have clear cut outright images and so on of certain stuff, right? Because if you all want the exam to come good, then I can't do that, right? Um, so that's that. But I will try to make it a little bit more visual. So today is respiratory pulmonology, respiratory medicine, which as a student was one of my, if not, uh, sorry, yeah, just trying to share the screen here. Yeah, cool. Um, cool. You all seeing the screen, right?
Yes, we are.
Okay, thank you. All right, cool. Yeah, so RESP was one of my least favorite. It still is. It still is. So my two least favorite subdisciplines in medicine are cardiology and respiratory. And practically, in terms of practical medicine, my least favorite is gastro. I like neurology and endocrine and renal, things that involve a lot of intense, like high, in-depth physiology. So neuro, endo, renal, those are my three favorites. Thinking about being a neurologist or a nephrologist, I had a fantastic, fantastic experience in nephrology, so I might probably go into that. But respiratory, oh my gosh, I didn't like resp at all as a student, and I still don't. But it is something that is highly tested, and a lot of when you become doctors, a lot of conditions that you'd see in your stint as a doctor, um, especially internal medicine rotation, would be thoracic cases, thoracic medicine cases, pneumonia and TB, LRTI and URTI, and all the respiratory tract infections and all the cancers and all of that. So it is critical to know, and all the COPD exacerbations, etc., all the pulmonary embolisms. RESP is huge. The world literally suffered blew from a pandemic that was of a respiratory nature, respiratory pathology or organism. So it goes to show, right? It is critical. I try to make respiratory like I do for everything else. I try to make it succinct and comprehensive at the same time. Now, I took Alexi's advice. I'm trying to do potentially the shorter part of the teaching today, and hopefully we finish, before 9 and so on. But um, RESP is a lot, okay? There are a lot of things that they can test on RESP. This is based on the patterns that I've seen. This class and these teachings are based on the patterns that I've seen. And it still is a lot of information. So for your RESP, I would, on Thursday, I want to get some better resources. I'm awaiting a resource. I would give you all a little more guidance as to how to study on your own. But Nonetheless, this obviously should answer like 80 to 90% of the questions still, right? But just know that RESP is huge. Neurology and RESP are the two hugest by far. Things like endocrine, gastro, they're very limited in what they ask, but RESP, neuro, they're huge, right? So we'll get through it, we'll go through it, and we'll try to answer and clarify any concepts. Okay, so without further ado, it is already 6:15, and I think that seems like it for my participants. Great. So we see the screen. So we'll start off. We'll do 6 questions, then we'll answer the first three, teach again, and answer the next three. But we'll start off answering the first 6 questions. So answers to number one in the chat, please, guys. Answers to number one in the chat, please. Thank you. Okay, good. And how are we going to approach this patient? Are we going to send them home, admit them to a hospital ward, or are we going to admit them to the ICU? Okay, good. Thank you, everyone. Oh, man, I think I, I was very apprehensive about having these. Someone said A, sure, about having the group this large, and I let quite a few students join because they expressed their need of the classes. But with this large group, you all answer a lot and a lot more confidently. So thanks for the answers. Love the participation. So number two, answers to number two in the chat, please. Answers to number two in the chat, please. Sure, I have less answers for this one. You have like about 14. I feel like the last one had about 20. Sure. Okay. Thanks, everyone. Right. Number three. Answers to number three in the chat, please. Answers to number three in the chat, please. Okay, thank you. Good. Number 4, answers to number 4 in the chat, please. Answers to number 4 in the chat. Okay. Number 5, answers to number 5 in the chat, please. Answers to number 5 in the chat, please. Right, so we have varying answers. Okay, so we have some teaching to do for RESP. That's nice. And um number 6. Forget what I said the last number was. Yeah, number 6. This is number 6. The chat blocking my numbers. Okay, yeah. Answers to number 6 in the chat, please. Answers to number 6 in the chat. Right, so fantastic, everyone. Fantastic. Great. Thank you so much, everyone, for answering. We will now begin to teach. Okay, you all seen the guide? Great. So, you know the drill. Any questions or concerns, just stop me on mute as well, right? Cool. All right, so good night, everyone, and welcome to Respiratory Medicine, Dr. Knight's PNP Part 1, Monday, the 17th of March. Guys, RESP is a lot, right? So RESP is a whole lot. I'm going to try as best as I can to bring the most high yield points across. It should cover 95%, 90% of what you need to know, but that 10% tends to come, right? So explore, keep on reading your respiratory medicine and so on. I'll send you all a couple of videos, and later down the week, I'll send you all a very particularly high yield resource to help you with pulmonology. Okay? So the first topic that we're going to do today, guys, the very first topic is the most commonly tested topic over the past 5 years. Now it does vary. Sometimes you'll see less of the respiratory tract infections and more of the chronic diseases, but overall we get to see more of the infectious diseases concerning thoracic medicine. So pneumonia and tuberculosis have come quite often in a plethora of ways, different things for the past 5 years of MBBS. All right. So the first thing is pneumonia. So let us do pneumonia. So pneumonia is respiratory tract infection of the lung. So it's an LRTI. It is not a URTI. It is not an otitis media. And remember that otitis media is a respiratory tract infection. It is not a sore throat. It is an infection of the lung. It's a lower respiratory tract infection. So the first thing to know about pneumonia would be the causative organisms and the different types of pneumonia that these organisms cause. So first we have community acquired pneumonia. Next we have atypical. Then we'll do a little bit about hospital acquired, which is HAP, aspiration pneumonia, and pneumonia in the immunocompromised. So, as we should know, overall, the most common bacterial cause of pneumonia is Streptococcus pneumoniae. Very, very easy to know. But remember that overall viral pneumonia is probably going to account for majority of the cases. But in the case of bacterial pneumonia, Streptococcus pneumonia is the most common overall organism. All right. Haemophilus influenza is seen in COPD and smokers and Moraxella catarrhalis. So what I want to point out here about these three organisms, guys, I want you all to make sure that you know about these three organisms is that they are also the common positive organisms in pediatrics you'll see for acute otitis media. Okay, so know everything about otitis media, write that down, wink, wink, wink. Know everything about acute otitis media in pediatrics. And when we reach the mock exam, I definitely will have a question on that. Streptococcus pneumonia and Haemophilus influenza in particular are encapsulated organisms, and we know that the spleen is responsible for breaking down these encapsulated organisms. And so, in whom might this phenomenon called asplenia be seen, guys? And thus, they are required to be vaccinated. Which category of patients? And I want you all to be very specific. Very good. So HBSS, aka I wanted you all to be a little more specific. So HBSS is sickle cell anemia. Okay, so sickle cell anemia, thanks Brianna, is not the same as sickle cell disease. When we do hematology, we'll see. So it depends on HBSS, HBSC, yada yada yada. HBSS is sickle cell anemia. In these patients, what tends to happen in these patients? It tends to happen in these patients with sickle cell anemia, that is HBSS. These patients, you have vessels going here. This is your spleen here. This is our spleen. You have vessels going here. In these patients, sickle cell anemia causes obstruction of the blood vessels. Obstruction of the blood vessels would mean that blood cannot go to the spleen and it leads to asplenia. Okay. However, in other patients with sickle cell disease, you have blood vessels obstructing here as well. And so they tend to have splenomegaly. Okay? So there's a difference, and when we reach the hematology, we'll see that difference. All right, but just remember sickle cell anemia is HBSS, and they are the ones with asplenia. Okay? So that's that. Yes, autosplenectomy. Fantastic. Fantastic, Julian. Right? So those patients are at high risk of strep pneumo and Haemophilus influenza, and so they require vaccinations. Okay? Now, I also have here that you can detect strep pneumo in urinary antigens. So that is just lower yield on the scale. The reason I had that there is because I saw it in a question. I did not MBBS, but no MBBS is pull questions from different sources. So remember that you could check urinary antigens for strep pneumo, but there is a course lower down where urinary antigens play a particularly specific role in diagnosis. Okay? Haemophilus influenza can be seen in COPD and smokers, and while Moraxella is less common. So that's community-acquired pneumonia. Those are the most common organisms that you'll see, and overall strep pneumo is number one. Next would be this phenomenon called atypical pneumonia, aka walk-in pneumonia. All right. So walk-in pneumonia, as the name implies, the patient is walking. They are walking and they are okay. They are not hospitalized. They are otherwise healthy. So atypical pneumonia or walking pneumonia presents atypically in a walking patient. Very easy to remember. The patient is otherwise healthy, and it tends to happen in younger patients as well. Right? Now, the most common overall causative organism, the highest, most likely cause of atypical pneumonia in a patient is mycoplasma pneumonia. Okay, so that is the most likely cause of atypical pneumonia, most likely, most common, most likely organism of walking pneumonia, mycoplasma pneumonia. All right. So these patients tend to present with not necessarily fever, cough, and rapid breathing, which is the classic triad of pneumonia or community-acquired pneumonia. These patients tend to present with upper respiratory tract infection symptoms. These patients had a preceding history of URTI symptoms like runny nose and sore throat, which is not typically seen in pneumonia, and that makes it atypical. They also have other extrapulmonary symptoms like muscle pain and joint pains. Okay, the cough tends to be dry. So atypical or walking pneumonia, otherwise young healthy patient with preceding history of upper respiratory tract symptoms and muscle pain and arthralgia. That is atypical pneumonia, and the most likely organism there is mycoplasma pneumonia. My alarm went off there, guys. Sorry. Yeah. So the difference between mycoplasma pneumonia and then you will see something called PCP pneumonia is this. Your mycoplasma pneumonia has a typical X-ray where they have one lower lobe having patchy consolidation. The consolidation in that lobe on X-ray is way out of proportion with the patient's symptoms. That means the chest X-ray looks bad, but the patient is otherwise healthy. And so that's a classic feature of mycoplasma pneumonia compared to PCP or the early onsets of PCP, where the patient is extremely sick, but their X-ray is not as bad. All right. So that's just a pimp point, right? Now, what is important about mycoplasma pneumonia and walk-in pneumonia is the treatment of choice. Because this is how this question had come for the last time it came. That is, a patient presented with walk-in pneumonia and they asked you the most appropriate antibiotic of choice. And the answer there would have been the macrolide. Okay, so we would use as first line in walk-in pneumonia macrolide, that's our mycins. Azithromycin and clarithromycin, less commonly seen in Trinidad, we use Itromax a lot here. Okay, so the first line antibiotic for a walk-in pneumonia is going to be a macrolide. All right. Now, in particular with mycoplasma pneumonia, remember this phenomenon called cold agglutinin autoimmune hemolytic anemia. And when we reach hematology, we'll speak a little bit about autoimmune hemolytic anemia. So mycoplasma causes a cold agglutinin autoimmune hemolytic anemia as well. So when a patient presents to you with walking pneumonia, you are going to assume it is mycoplasma, and therefore you cover with macrolide antibiotics. So that's the concept behind if you just have a presentation with a patient with walking pneumonia. Now, what about if they tell you, well, the patient has chlamydia pneumonia? Well, it presents similarly to atypical to mycoplasma because it's a walking pneumonia, but the treatment option there, first line would be doxycycline, as doxycycline is used to treat most types of chlamydia organisms, right? Chlamydia pneumonia is not the same as chlamydia trachomatis, of course, right? It's two different bacteria, but they're within the chlamydia genus of bacteria, okay? So in the instance where they just present with walking pneumonia, macrolide first choice. But if they tell you this is chlamydia pneumonia as a cause, then you go with the doxy as a first line antibiotic, all right? So that's that. So mycoplasma, walking pneumonia, otherwise healthy patient, arthralgia, myalgia, upper respiratory tract symptoms, very severe patchy consolidation in one lower lobe, and this patient we cover with a macrolide. So the atypical pneumonia organisms I have here, and I'm actually now, right? MCL, that's mycoplasma, chlamydia, and legionella, the common ones. I'll talk to you all about the others. We spoke about chlamydia, you really just need to know the treatment. The other one, guys, that pops up is legionella. That's another one that pops up. So legionellosis is a disease in and of itself, but we're speaking about legionella as manifesting or presenting as an atypical pneumonia. Now, what is going to clue you in here is the patient class that legionella takes place in. And these will be patients who went on vacations on a cruise ship and have been exposed to aerosols of contaminated water. So legionella is seen in plumbers who worked on a sink. It's seen in cruise ship and vacationers. They are the ones in your question stem when you're looking at your demographics and history that you're probably going to think Legionella. But what they're going to tell you as well would be these hosts of extra pulmonary symptoms. I don't have them here, but very important for Legionella is this hyponatremia picture, a low sodium, and this liver involvement, deranged LFTs. Okay, so those are the things that are seen pop up most commonly to point towards Legionella. Aerosolized contaminated water exposure, patients have this atypical pneumonia features with some deranged LFTs. They're febrile and sick otherwise, have a little hepatomegaly, and you look at the sodium level, it's low. Now, the diagnosis of Legionella is important, guys. Urinary antigen. We have to do a urinary antigen test to detect Legionella species. Okay, so Legionella urinary antigen. It's not so for strep pneumo, it is so for Legionella. So that's where the urinary antigen takes place or comes into play. The treatment of legionellosis is with fluoroquinolone or a macrolide. It's hardly ever likely that they'll bring both as options, but I will show you when we reach curve 65 what they do to trick you guys. All right. So that's Mycoplasma chlamydia legionella as atypical pneumonia. And the other causes that pop up quite frequently would be Coxiella chlamydia psittaci. And just remember that Staph aureus is a cause of not community acquired, but atypical pneumonia. It's not a common community acquired type of pneumonia. Okay, these are the three up here. We'll put Staph here in our atypical pneumonia. So Coxiella we would have spoken about in infective endocarditis, and we said it causes Q fever, and I told you all you would see it here again, because this is more often where I see Coxiella burnetii. Coxiella is seen in abattoir or butcher workers because it happens in patients who have had exposure to sheep placenta. Okay, and the treatment of Coxiella is doxycycline. So what you're going to see in the question stem, a butcher or abattoir worker presents with either infective endocarditis symptoms or pneumonia symptoms, atypical pneumonia symptoms. That's Coxiella, that's Q fever, treat them with doxy. They hardly ever go too much into Q fever, but you could read up a little bit more about it. All right. The last one that I'm going to speak about in depth, guys, is chlamydia psittaci. So chlamydia psittaci is very specific. It is causes an ornithosis. Ornithosis is an infection acquired from birds. It is an infectious pathology. Psittacosis caused by chlamydia psittaci is an infectious pathology. It is an atypical pneumonia. All right. There are a lot of extrapulmonary manifestations, and it's quite similar to Legionella in the presentation. In terms of you have liver involvement, you have all of these kinds of things, kidney involvement, yada yada. But what they are going to tell you is that the patient is a keeper of not just birds, but parrots. So two things for chlamydia psittaci or psittacosis would be, apart from the atypical pneumonia features we described with muscle pain and sore throat and cough and yada yada, the two things would be extra pulmonary manifestations, hepatomegaly and deranged liver function, etc. But these patients also keep birds, and that's parrots. They often tell you the patient has pet parrots. Okay, chlamydia psittaci or psittacosis is not to be confused with what we're going to do on Thursday, and that is bird fancier's lung. Bird fancier's lung is not a pneumonia. It is an interstitial lung disease. It is an interstitial lung disease of the class hypersensitivity pneumonitis. It is an extrinsic allergic alveolitis. We'll talk about that on Thursday. That is not an infection. Okay, that is inflammation and interstitial involvement. Psittacosis is an infection caused by chlamydia psittaci. And because it's of the chlamydia species, we treat with doxycycline. So please do not confuse psittacosis with bird fancier's lung, which we'll bring all together, bring around when we do it further on Thursday. Right? So psittacosis seen in parrot keepers, a lot of extra pulmonary manifestations. So look out for that as chlamydia psittaci as a cause. All right? Staph aureus. Remember that Staph aureus, guys, is a pneumonia seen in post-influenza vaccination. So post-flu vaccine, the patient develops a pneumonia in a question stem. think Staph aureus, and of course, Staph aureus, commensal organism on the skin, and so IV drug users causes Staph aureus pneumonia and of course Staph aureus infective endocarditis as we would have done. All right. So it's not a typical classical cause of pneumonia as some may think. And well, when we're talking about Staph aureus pneumonia, our main concern really is MRSA, which we're going to talk about now. So guys, we said strep pneumo, H flu and varicella for CAP, community acquired. Atypical pneumonia, our patient, otherwise healthy, young, walking, myalgia and arthralgia. Most common organism is mycoplasma pneumonia for atypical, but we have to remember chlamydia, legionella, coxiella, chlamydia psittaci, and staph aureus. Each of these organisms, I think, who was I speaking to? I forget. I think it was Alima, was saying things like positive organisms tend to come because she did her exam for end of clerkship, and yes, the same applies for MBBS as well. They like to ask you about these organisms and stuff. All right, so that's that. Next is hospital-acquired pneumonia. So hospital-acquired pneumonia, guys, has a particular definition. It is pneumonia acquired 48 hours after admission to hospital. Not the patient come in today and tonight they develop a pneumonia. You need 48 hours after admission to hospital to call it this hospital-acquired pneumonia. Now, a very common way of acquiring pneumonia in hospital is ventilator-associated pneumonia, right? Now, the reason for that is because patients who are ventilated, remember, we have to have them sedated. We also have them on things like PPIs. And so with that sedation, they aspirate, and with the PPI, we have gastric acid suppression. So they aspirate all the bacteria. So that's how they develop this hospital-acquired pneumonia. It's oftentimes due to ventilator association, right? But the causative organisms is particularly high. A patient develops pneumonia in hospital, you got to put them on Zosyn. You're thinking hospital-acquired pneumonia, you got to put them on Zosyn and Mero, okay? So piptazo, piperacillin, tazobactam, and meropenem. Why? Because Pseudomonas aeruginosa is what you are thinking of. It is the most common cause of hospital-acquired pneumonia, especially in ventilated patients and the immunocompromised. Excuse me. So Pseudomonas aeruginosa we cover for, and then our other organism, especially for ventilator-associated pneumonia, would be MRSA, methicillin-resistant Staphylococcus aureus. Sorry. So before Staph aureus could have been covered with flucloxacillin, stillin. Now Staph aureus has become resistant to the cillins, and so we have this methicillin-resistant Staph aureus, and the treatment of choice for MRSA still, thankfully, vancomycin tends to work. So piptazo and vanco is usually what we would at least consider combining in patients with hospital-acquired pneumonia. Now, of course, every hospital has its antibiotic regimen. In Mount Hope, we use meropenem a lot. So it's not always Zosyn, which is piptazo. We use a lot of meropenem. We hardly actually use vanco. But when I'm speaking about like guidelines-based medicine, this here is a reasonable regimen. Vanco with piptazo, and you add on a respiratory fluoroquinolone or aminoglycoside like gentamicin and stuff, right? Vanco always usually goes with gentamicin to cover both gram-positive and gram-negative organisms, respectively. Okay? So Pseudomonas MRSA and Klebsiella also causes Corongelli sputum. Klebsiella pneumonia is seen in diabetics and alcoholics. So if you see an elderly diabetic alcoholic patient in a question stem, elderly diabetes, they have a history of alcohol consumption, they're going to kind of paint this Corongelli sputum picture. You're thinking Klebsiella is the cause there. All right, and the treatment is with a cefotaxime, covers Klebsiella pretty well. There are other causes of hospital-acquired pneumonia, and that will be a whole lot of gram negs, and that's why we tend to put them on meropenem or add on aminoglycoside as well. But hospital-acquired pneumonia, guys, think ventilator-associated pneumonia, ventilated patients, and so they are on mechanical ventilation, they go on to develop this infection. You're going to say Pseudomonas as a cause or MRSA as a cause there, right? And we know how to cover there. So that's community-acquired, atypical pneumonia, and hospital-acquired pneumonia. Okay, so this is a reasonable regimen. Learn all of the organisms, guys. Learn the appropriate antibiotics, the targeted antibiotics per organism. Okay? We do have aspiration pneumonia that pops up a lot. And the thing about aspiration pneumonia, please guys put your patient on flagyl, add one on metronidazole, as well as cephalosporin. So something like ceftriaxone and flagyl should give you good coverage. Okay, so many times we just cover the patients with ceftriaxone as a broad spectrum. But if you're really convinced it's an aspiration pneumonia, it makes a lot of sense to cover for your GI anaerobes with metronidazole. So that's a decent thing there. So aspiration pneumonia could be seen in patients who have things like strokes and so on. All right, good. So that's hospital-acquired atypical community pneumonia. Guys, pneumonia in the immunocompromised. Guys, okay. So probably if I write it. So PCP, pneumocystis pneumonia. That you need to know everything about. PCP, pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia is seen in the immunocompromised, especially HIV patients with a CD4 count of less than 400. On my slides, I have 200, but this has been updated. It can be seen in HIV patients with a CD4 count of less than 400. The whole point about pneumocystis pneumonia is that it's seen in the immunocompromised, and once a patient has HIV and they come in with respiratory symptoms, it's going to think either TB or PCP. All right? Everything about PCP you guys need to know, and that's why I'm writing it down. But the most high points about PCP is the presentation that helps differentiate it from a community-acquired pneumonia that is a dry, non-productive cough. PCP, pneumocystis pneumonia, does not classically present with a productive cough of any type of sputum. And that is a particularly high feature in your HIV patients. Because if they present with something like a TB or another community-acquired pneumonia, because they are susceptible to all organisms, they may have a mucopurulent cough or they may have a hemoptysis or something like that. PCP has a dry cough. Another classical presentation is desaturation on exercise. So anytime they have exertional dyspnea and a PaO2 that is greatly reduced, that is PCP pneumonia in your PC pneumonia, right? Well, PCP pneumonia is pneumocystis pneumonia. That is PCP until proven otherwise. So a resting PaO2 that is very, very low, out of proportion to your clinical picture. The patient having desaturation and exercise. They have fever, weight loss, and night sweats as well. But the cough is dry. You're thinking PCP. Okay? So that is PCP. What else do we need to know about PCP? What we need to know about PCP is our chest x-ray, and our chest x-ray is usually out of proportion to the clinical features. The patient is very, very sick, but you only have these widespread pulmonary infiltrates, right? It doesn't look as sick as the patient is. So they have some widespread pulmonary infiltrates, but it's not like a whiteout that you would think, damn, this patient have a ARDS or something. Okay? It's not that bad. To diagnose PCP, however, diagnosis definitively, because once you have that reduced PaO2 in immunocompromised patients with a chest x-ray that shows widespread pulmonary infiltrates, especially if they have HIV, you're thinking PCP. But to definitively diagnose this, you need to see the organism on histology. And so for PCP, histology, we can get it via the sputum, or very importantly, I've seen this pop up, bronchoalveolar lavage, as what you're going to do to definitively, oh gosh, this is LAVAGE, right? Bronchoalveolar lavage. Right, guys? To definitively diagnose PCP, I've seen this question pop up, bronchoalveolar lavage. Bronchoalveolar lavage is one of the few indications where a bronchoalveolar lavage is used first line, especially in your MCQs. Okay, so that's another thing you need to know about PCP. Another thing you need to know about PCP, guys, is that beta D glucan is something that is seen in all of your fungal organisms, because this is a type of fungi, and it can be used to aid diagnosis. Okay, so this is PCP. Beta D glucan can be used to aid diagnosis. The other thing about PCP is that it leads to LDH levels being very high because you have chronic hypoxia and so on, and tissue damage. And so your lactate dehydrogenase levels are extremely elevated in PCP pneumonia. Okay? The last thing I want you all to know about PCP pneumonia, guys, is the treatment. And the treatment of choice is commonly 21 days of Septra, which is trimethoprim sulfamethoxazole. However, this is not always tolerated, and there are a host of alternatives. A very common one you'll see is pentamidine. You may see dapsone, and you may see others. Okay? But the gold standard would be Septra, which is 21 days of trimethoprim sulfamethoxazole. So you're thinking PCP in your immunocompromised patient, you're starting Septra one time, trimethoprim sulfamethoxazole. Pentamidine is an alternative, and in patients with sulfur allergy, pentamidine can be used as prophylaxis. So in patients with PCP, in patients with HIV, their CD4 count gets less than 400. We can give them prophylaxis with pentamidine, dapsone, and other things. All right. So everything that I just said, guys, in some way, form, or fashion, can be tested for PCP. So pneumonia in the immunocompromised, the most common one that appears is PCP, pneumocystis pneumonia. I do not have all of that on the slides, and that's why you're paying attention. Okay? So pneumocystis, exertional dyspnea, desaturation, and exercise. Septra 3 times per week as prophylaxis, yes. But we can also use pentamidine as prophylaxis or other things if they have sulfur allergy. But everything I said, beta-glucan, LDH levels, bronchoalveolar lavage, all of those things have been tested and can be tested again. Wink, wink, wink. Right? So that's not on the slide. So CD4 count less than 50. So this is immunocompromised patients, but we're thinking about HIV, right? Now, of course, every patient who's immunocompromised has a greater risk of every infection. And so all the other causes before of pneumonia, obviously the patients who's immunocompromised is at higher risk. But we're thinking about specifically organisms that cause pneumonia if the patient is immunocompromised, right? So PCP is one if the CD4 is less than 200, Cryptococcus, etc., etc. The other one that tends to pop up, the other organism is Aspergillus. Okay, so Aspergillosis has about 5 presentations. I do have a question on aspergillosis in the homework, so you need to read through the answers when I send you it. I'm not going to spend a whole 10 minutes talking about aspergillosis. It's not commonly tested, but if they do bring pneumonia and immunocompromised, aspergillosis tends to come. What they like to ask about aspergillus is they give you the list of antimicrobials to choose from, and they include fluconazole or amphotericin B, and many a time amphotericin B is the answer. So the treatment of choice in that case, where you have this list of antimicrobials, just remember fluconazole does not cover aspergillus. It is not effective against aspergillus, though it's a fungus. Amphotericin B is. However, can anyone tell me what is now the treatment of choice for invasive aspergillosis? Because as I said, you have aspergilloma, you have allergic bronchopulmonary aspergillosis, etc. But in a patient with invasive aspergillosis, the antimicrobial of choice in that case, guys, this is new information, is voriconazole. Okay, so voriconazole is first line in invasive aspergillosis. Okay, this is particularly high yield because this wasn't always so. But they found with research as voriconazole is greater effective and it's better tolerated, right? So that's aspergillus. The other thing on this slide that is particularly important that pops up is Rose Handler's disease. And so they'll tell you this gardener went to pick his rose and a thorn stick him. And what is the causative organism there? Sporothrix schenki. Okay, so sporotrichosis is a rose handler's disease. Sporotrichosis, that's how you remember rose handlers, and that's how you remember the organism. That's Sporothrix schenki. I've seen this pop up many, many times. Now, rose handler's disease or gardener's disease is not to be confused with farmer's lung. Farmer's lung is also a restrictive lung disease. It is an interstitial lung disease. It is not an infection. It is seen in farmers, and we'll see what. Can anyone tell me what the causative organism of farmer's lung is? Instead of waiting for Thursday, because I've seen this pop up quite a few times, at least 2 or 3 times. So farmer's lung is caused by Micropolyspora fani. Okay, Micropolyspora fani is now termed Saccharopolyspora rectivirgula. Okay, that's a new name for Micropolyspora fani. Now, there are many other causes of farmer's lung, but this is by far the most common. So farmer's lung is actually a interstitial lung disease. It's a hypersensitivity pneumonitis, not to be confused with the gardener's disease, the rose handler's disease, which is caused by Sporothrix schenki, and usually in immunocompromised patients. Okay, so it's very, 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 very important for you all to know the organisms, the causative organisms, and not to mix up pneumonia with hypersensitivity pneumonitis. All right, so that's that. So this what we're talking about here is pneumonia. All right, CD4 less than 50, all the other organisms, CMV, Mycobacterium avium complex, histoplasmosis, all these things we know can cause pneumonia as well. These are all the fungus and things, right? CD4 less than 500 increases the risk of TB, and CD4 more than 500 tends to have no increased risk. I talk about HIV when we do infectious diseases, but from a pneumonia standpoint, guys, PCP, everything I said about PCP, you can read up a little bit about PCP again, but those are the most high points. You need to know everything about pneumocystis pneumonia. All right, good. So the clinical features of pneumonia, I'm not going to go through because I expect you all to know fever, chills, cough, sputum, could cause a hemoptysis, pruritic chest pain, etc. Tachycardic, tachypneic, right? Typical things, right? You all know how pneumonia presents. You all are big EFI medical students. Good. What I want to point out here would be our blood work for pneumonia, and pneumonia tends to show a type 1 respiratory failure. So can someone tell me what's the difference between a type 1 and a type 2 respiratory failure? Good. So Abigail says type 1 is hypoxia only. Excuse me. And type 2 is hypoxia and hypercapnia. So type 1, she is correct, is not hypoxia, but we'll go with that. Hypoxemia, that is a low PaO2 with a normal PCO2. So type 1 respiratory failure, just remember you have one thing off, and that's your oxygen. In type 2 respiratory failure, what do you have? You have a low PaO2 plus a high PaCO2. So you're hypercapnic and hypoxic. And so for type 2 respiratory failure, you have two things wrong. For both of them, your oxygen levels are reduced, but in type 2, your carbon dioxide levels are increased, it's retained. And so type 1 versus type 2 respiratory failure, guys, is common because you need to know a little bit about the causes of them. So a type 1 resp failure, think about it, right? Type 1 resp failure, this is due to a VQ mismatch. VQ mismatch, ventilation perfusion mismatch. You have the blood vessel here, you have your alveoli, right? So usually oxygen is supposed to transport to your blood. This is called perfusion, and if you have oxygen in your lungs, this is called ventilation. So if you have a ventilation perfusion mismatch, it's going to prevent oxygen from going into your bloodstream, and that's how you end up with a low PaO2. Hypoxemia. This is seen in type 1 respiratory failure, and therefore the things that cause a ventilation perfusion mismatch will be things that cause lung damage, things like shunting, where you're shunting blood away, and other conditions. But very commonly, for type 1 respiratory failure, I want you all to write down that is caused by a pneumonia, pulmonary edema, and pulmonary embolism. Okay, so these would cause a hypoxia with normal CO2 levels, not necessarily a hypercapnia. Okay, so that's type 1 respiratory failure there. Next would be type 2 respiratory failure. So in type 2 respiratory failure, what happens is we have hypoventilation. So usually what this leads to is CO2 trapping or CO2 retention. And so anything that can cause CO2 retention would lead to a hypoxemia picture because it can't properly oxygenate the lungs, but also a hypercapnic picture, an increased PaCO2. And so, of course, our obstructive lung diseases, things like COPD, things like bronchiectasis, can cause a type 2 picture. And remember, our neuromuscular diseases like Guillain-Barré syndrome, etc., where you cannot expire, would lead to CO2 trapping, increase your PaCO2 levels because you're not breathing out the carbon dioxide, and lead to a type 2 respiratory failure. So guys, I do not have anything in my guide about type 1 and type 2. And it's only as I was reading that and teaching that I realized that type 1 and type 2 respiratory failure can come. You need to know the differences, you need to know the different causes of them. All right, so type 1, hypoxic and normal CO2, but type 2, two things off, hypoxic and hypercapnic. And we know why that happens now. We know how that presents. Okay, so pneumonia would cause a type 1 respiratory failure along with pulmonary edema and pulmonary embolism. Okay? Good. So the last thing, guys, about pneumonia, and this should cover most of what comes from pneumonia, right? You could do a gram stain and culture, blood culture, etc. to define the causative organisms. Remember, Legionella would give you urinary antigens and so on. For PCP, we want to do a bronchoalveolar lavage. Okay, so know the differences. There are little caveats here and there, but for the most part, it's generally sputum with gram stain or blood cultures to see organisms, right? The last thing for pneumonia, guys, is the treatment of community-acquired pneumonia based on guidelines, based on evidence-based medicine, CURB 65. All right. So CURB 65 is this scoring system that allows you to make a decision as to how to treat a community-acquired pneumonia. The C stands for confusion, the U stands for urea, the R stands for respirate, and the B stands for blood pressure. You need to know these particular numbers. So confusion is C, urea is more than 20 milligrams per deciliter, also more than 7 millimoles per liter. So depending on your unit, the score varies, all right? So milligrams per deciliter, which is what we use here in Trinidad, that's 20. But they can also give you it in millimoles per liter. Respirate is 30 or more than 30, and blood pressure only gives you a score of 1, regardless of if the patient has both a low systolic and diastolic. You only get a score of 1, and that's for a systolic less than 90 or a diastolic less than 60. If it's 80 on 40, that patient still only gets a score of 1. All right? And then 65 is the age, 65 years or older. So for CURB 65, each of these points give you a score of 1. So if the patient is confused, if they have a high urea level, they're very tachypneic, more than 30, BPs are off, or they're older than 65, you get a score of 1 for each. So it's a maximum of 5 points. A score of 0 to 1 would allow for outpatient treatment. A score of 2 allows for hospital ward treatment. And a score of 3 to 5, these patients we send to ICU. Now, this is where the questions come for MBBS. Your antibiotic regimen of choice. Guys, you just need to learn this and learn it well. There's no beating up or trying to bust your brain. Just learn this here. Now, in real life, antibiotic regimens apply. It's different per hospital, but MBBS tends to bring this clear cut, but still to confuse you. And I'll show you where the confusion is. So for outpatient, CURB score of 0 to 1, a CURB score of 0 to 1, we're going to treat them as an outpatient. Okay? So CURB score 0 or 1, outpatient treatment.
Usually, we would give them monotherapy with either a macrolide or doxycycline or an anti-pneumococcal fluoroquinolone. So learn that well. So usually we just give them azithromycin, send them home. Usually we give them doxy, send them home, or usually we give them an anti-pneumococcal fluoroquinolone. But in some cases, if they have very increased risk of resistance, we give them a macrolide in combination with amoxiclav for broader coverage. So what MBBS does is this. MBBS says a patient coming with pneumonia curve 65 or 1, and they tell you, how are you going to treat this patient? And they tell you, we're going to give this patient, let's see, we're going to give this patient Piptazo. We're going to give this patient Cipro. You're going to give this patient, um, what was the exact option, boy? It was Piptazo. I'm trying to remember this question from me top of my head. Piptazo. Cipro. All right, let's make it easy. So for simplicity's sake, vancomycin, and then they tell you that they're gonna give the patient um so increased risk of resistance would be immunocompromised patients and elderly patients and so on, right? Or if they have comorbidities and so on. But the question that MBBS tends to bring is this: community acquired pneumonia score of 1. A. Piptazo, Cipro B, Vanco C, Levo plus amoxiclav D. What's the answer? Why? Write in the chat. A is Piptazo, B is Cipro, C is Vanco, D is Levo and amoxiclav. You get no other information, but the patient has pneumonia with a curve score of 1. You have no other information. This is what MBBS does to you. They bring what is most correct, what is least correct, what is most correct. One set of close answers. Nobody's typing in the chat what you're going to do there. Okay? All is shy, or we nobody wants to give a guess. A, B, C, or D? C or D? All right. So Karina says D and Samuel says D. Karina, why you say D? You can unmute if you want. Karina, you're shy. Karina is just guessing D, Samuel is guessing D. Nobody else has anything else to say. All right. So thanks, Karina and Samuel. Samuel, you want to tell us why you say D? Samuel? Because nobody else seems to want to answer me. So, and this is an actual MBBS question, and you all don't want to try to answer it. Come on, guys. These the kind of ones you want to try to answer, because obviously I'm going to tell you the answer. If you type a wrong answer, remember it. Samuel is not responding to me. So I'm going to assume Samuel probably just guessed, and Rico says B. All right, guys. Fine. Sure, wasn't enough coverage. That's fine. That's fine. But the better reasoning for the answer, and I like how Tahira and Jody says B, because we just saw monotherapy with a macrolide or a monotherapy with an anti-pneumococcal fluoroquinolone. Tahira says no comorbidity. Good. That's good thinking, and I love to see the thinking, but this is why MBBS is MBBS. What this here? Watch this here. Respiratory fluoroquinolones are moxifloxacin, gemifloxacin, and levofloxacin. Ciprofloxacin has little to no sensitivity against Streptococcus pneumonia, and so for a community-acquired pneumonia, evidence-based medicine says you do not give ciprofloxacin. We keep Cipro for our UTIs and stuff. So in this patient, we need a respiratory fluoroquinolone, and that is levofloxacin. And so that's why the answer in this case was levofloxacin and augmentin or amoxiclav. simply because you could not use ciprofloxacin, and out of the options they give you, and that's how they ask the questions, which of the following options is most appropriate? And therefore, wording and phrasing of questions is important when you're taking MCQs. Of the following options, the most appropriate would have been an anti-pneumococcal fluoroquinolone. So that's levofloxacin. And they just added on amoxiclav to make it seem like it's wrong, to make it seem like you can't give it because you usually give monotherapy. But because of how the question was phrased, that was the answer. Are we clear, guys, on that concept? Because I've seen that question come in a variety of ways 3 times in the past 2 years. And it's always got done wrong because everyone usually chooses ciprofloxacin. Are we clear? Yes? No? Maybe? Solene? So your respiratory fluoroquinolones are your anti-pneumococcal fluoroquinolones, and that's moxifloxacin, gemifloxacin, and levofloxacin. We do not use ciprofloxacin. It is not an anti-pneumococcal fluoroquinolone. We don't use that for pneumonia. Okay? So if we are to use of the options there, we have to use levofloxacin and the amoxiclav because that was the only option that made sense. We're not going to use our piptazo. We're not going to use our vanco for a simple community-acquired pneumonia. Okay, so those were obviously wrong. And that was the reason for that answer. All right? Good. So, curve
Yeah.
score I, Orencia.
Yes, a question. Someone asked earlier in the chat what fluid to increase risk of resistance. So just wanted to.
I had answered. I told her things like elderly patients with immunocompromised patients, diabetes, all of those things. So anything that makes you more likely to be immunocompromised would indicate an increased risk of resistance. Okay?
Oh, thanks.
Sure. Good. So hospital curb score of 2, ICU curb score of 3 to 5. So for the curb score of 2, this varies. You could use an anti-pneumococcal fluoroquinolone alone. You could combine ceftriaxone with amoxicillin or doxycycline. And for these patients who have a curb score of 2, our regimen in Mount Hope is we give them ceftriaxone and doxycycline. All right. So I've seen that pop up in 2021 and was actually pretty interesting because not all the time you see things that they do on the wards in past papers, right? But we actually give ceftriaxone and doxy for the patients who we admit to hospital for pneumonia, right? It's not hospital acquired pneumonia. It's the fact that on presentation, their pneumonia gave us a curb score of 2. We admitted them to hospital and we treated them for the pneumonia in hospital with Kef and Doxy, or you could use a macrolide and doxycycline as well, or monotherapy to anti-pneumococcal fluoroquinolone is appropriate. And then we have this here as well. All right. So let's learn of these antibiotic regimens. And then ICU admission, it's very easy. You just need to hit them hard, okay? This curve score is 3 to 5. It's probably some nasty organism. The patient is probably at some level of immunocompromise as well. And so if they have a curve score of 3 to 5, look at that. The patient is confused. They have a high urea and it's tachypnic. That sounds bad. Or if they have a blood pressure dipping with the tachypnea and they all that sounds bad. So once it looks bad, it sounds bad, you send them to the ICU and you hit them with the IV beta lactam like piptazo, mero, imipenem, ceftriaxone, plus an anti-pneumococcal fluoroquinolone or macrolide. So it's usually dual therapy for ICU, ensuring you have an IV beta lactam and some other very fantastic fluoroquinolone or macrolide. All right, so it's very easy for the ICU admissions. You're hitting them hard, real hard. So one of them real strong antibiotics plus something else. Okay, so let's learn out this as well. So this is your guidelines-based medicine, and that question I wanted to show you all because that question is the one that tricks you all the time. And I'm glad that we're clear on that concept. Okay, so just remember your respiratory fluoroquinolones, migrate lungs, MGL, Moxi, Gemi, Levo, Fluoxacin. All right? Good. Any questions on pneumonia, guys? Are we clear about pneumonia and the causative organisms, the curb score, PCP, all of the different forms, type 1 and type 2 respiratory failure? Any questions Any concerns at all? All right, thank you, Alia. And so, what is the common adverse effect of fluoroquinolones that is commonly tested and unique? What does fluoroquinolones cause? Anybody? So fluoroquinolones are associated with, yeah, good. That's good thinking, Dijonel. But you're doing more questions, you'll see tendon rupture, right? So they like to bring fluoroquinolones as causing tendon rupture. So just remember that going forward in your MCQs as well. Great. So good. So now we're coming back here because we're gonna do the 3 questions, then we'll teach TB, and then the other 3 topics are pretty short. Good. So number 1, I think almost everyone will have got that correct. So fantastic. So this is a 63-year-old woman admitted to accident and emergency with pyrexia, productive cough, green sputum, but she's 63, so that's a score of 0 there. Her pulse is 104, her BP is 150. So this BP less than 60 diastolic gives us a score of 1. Our respirate is 28, it's less than 30, so she doesn't get a score there. She is alert and oriented, so she's not confused. Her blood results reveal a white cell of 21. We're not considering white cell for curve 65, but a urea of 34. This should have been milligrams per deciliter. Pardon me for the error, but it's still more than 7 and it's more than 20, so she gets a score of 1. So a BP of less than 60, a diastolic BP of less than 60, and a urea of more than 20. So that's 1 plus 1. Her curve score is 2. We would admit her to the hospital and we'd probably give her cephalosporin plus doxy or a macrolide plus doxycycline or an anti-pneumococcal fluoroquinolone like levofloxacin or gemifloxacin. All right, so that's that. Fantastic job. Can I have answers to number 2 in the chat, please? Fantastic. And so what class of antibiotic, or give me an example of the first line agent in this patient? Antibiotics. Yep, fantastic. And macrolide, azithromycin, clarithromycin, because this is our clear-cut case of atypical walk-in pneumonia. 24-year-old male, never smoked, no past medical history, otherwise well, but he had this persistent dry cough, had some upper respiratory tract symptoms before, and now his vitals are okay, he's otherwise healthy, but the chest x-ray shows consolidation of the right lower lobe. All right, so this here is typical mycoplasma pneumonia. So chlamydia pneumonia can present very similarly, but because the same most likely organism, mycoplasma is the most likely cause of atypical. Good. Number 3, answers to number 3. So that's Julian's question. Chlamydia pneumonia is an atypical pneumonia, right? So it presents atypically, just like all the atypical pneumonias, right? So they have the same presentation, but if you're thinking about the most likely organism, then we would, of course, think mycoplasma. So yeah, answers to number 3. What is this patient's most likely diagnosis? PCP. Good. So can someone tell me why they chose A as the answer? Because I saw most people choosing A. Anyone? was either A or C, and C looked correct. Read it wrong, then C least likely. Okay, so good. So that's why I do these questions in class, right? So guys, there it is, right? So don't be too brave to jump on through. And then that also means that you all probably did not read all of the other options. Or when you read all of the other options, you probably didn't associate it with being factual about PCP. Because if you read A, let's say you misread the question. So this is an MCQ taken caveat, right? Or tidbit. You read the question, but you only watch one answer. Treatment is with 21 days of trimethoprim sulfamethoxazole. They say that is the answer. That means they didn't look through here and say, hey, but this B is also true, and E is also true, and D is also true. And or if you didn't recognize B, D, and E as true, means I didn't properly read PCP. All right. So remember, two tips: always read through your questions properly. Always read through your entire question properly. Take your time, read through it properly, and then always read through your answers. Because a big point is two answers are not going to be correct. Okay. So if you find things looking a little too strange, sometimes yes, one is more correct than the others. But other times it is because those two answers are to be ruled out or excluded. So that's another tip, right? So yes, for PCP, this is the classic presentation: fever, weight loss, cough in an HIV patient. And we said that they have exertional dyspnea with desaturation and exercise. So she has dyspnea after walking long distances. And we also said that their PaO2 is oftentimes greatly reduced. Right? A chest X-ray isn't bad, but this is a classical widespread kind of pulmonary infiltrates here bilaterally. This is kind of a classical PCP X-ray here. And a CD4 count is less than 150. Okay, so treatment for PCP, yes, is usually 21 days of Septra, trimethoprim sulfamethoxazole. Pentamidine may be used for prophylaxis. Beta-D-glucan can aid in diagnosis, and LDH levels can be elevated as well. We said classically for PCP, they actually have a dry cough, and that helps distinguish it from a community-acquired pneumonia. All right, but these patients are very sick, at risk of dying, especially the HIV patients who are severely immune compromised. So yeah, and remember bronchoalveolar lavage's role in diagnosis. Cool, great. So any questions on pneumonia, guys? Are we clear? Yeah, no, maybe. Okay, great. So it's a huge topic. I know I took a lot of time, but we did speak about PCP in depth. We did talk about type 1 and type 2 RESP failure and so on. So make sure you all pay attention and took note of those things. Take note of everything I say. Okay, great. So we'll take a 5 minutes now. Then we'll come back. We'll do TB. TB is shorter than pneumonia. I'll point out what they test about TB. And well, the other three topics are really kind of low yield, right? But I cover it. And then Thursday, I'll cover the more higher yield ones. And so what I'm doing now is I'm combining high yield and low yield. Whereas last week, Monday, I did the most high yield first up front. So I think that's why class took so long. So it shouldn't go like beyond 9 and thing anymore, right? With that approach. So we'll start back at 7:32. 7 minutes break. Thanks, guys.
Seth,
Hi, Alima.
hi, I just have a quick question. You said according to the guidelines, they changed it to CD4 count less than 400 for PCP, right?
According to the guidelines in my reading, I saw that it's not really like a guidelines thing, but in terms of, so classically when we doing CD4 count levels in HIV patients, we categorize it CD4 less than 500, less than 200, less than 100, less than 50, right? As in terms of the risk of the organisms that are likely to cause infection in those patients. But in my reading, I saw that they are seeing PCP now in patients with a CD4 count of as high as 400 and less. So meaning that PCP is getting more, how to put it, aggressive, I guess, or has a greater propensity for infection, even with better immunostability or better immunity overall. Right? But classically, it used to be a CD4 less than 200, but now I see it's CD4 less. So that's why I put that there.
Okay, no problem. Thank you.
Mhm. You're welcome.
Hey, hey everyone. Let's see. Let's go down this line here. So you have spoken to Leon. Okay. Okay. I think I spoke to all the Bohemians already. Ayuka? Ayuka? Alright. If Ayuka is there, Ayuka is not responding. Alright. Really shy. Guys, you need to put your campus next to your name, okay? Please. Appreciate that. Let's see. Leandra? I see you have Cave Hill there.
Hi, good night.
Hi, Leandra. Leandra, where are you from?
I'm from Trinidad.
Yeah, you from Trinidad. I had a mind, so I hear your accent. How have the classes been for you?
The classes have been good. I learn a lot. A lot of it is also like going over stuff I heard before. So it's more so like to practice with some space repetition so I remember all the information.
Fantastic. Right? And when you're coming back to Trinidad, or you're never coming back, you're gonna live Barbados.
Well, actually, I'll be coming back for an elective for my 5th year, and that will be in May. But in terms of working, I'm not too sure where I'll be settling to work as yet.
Okay, cool. No problems. And wait, last question. You think Trinidad is nice or Barbados is nice?
In terms of what exactly?
In terms of however you want to imply.
Um,
Put you on the
personally,
spot.
I
Your
find
own
that
opinion.
Barbados is a bit quieter than Trinidad, so that's something that I appreciate. But in terms of food wise, I would always prefer Trinidad.
Melina, say Barbados. Melina is rapping. Thanks, Leandra. Food-wise, definitely food-wise. I don't think the Bajans could be too upset about that, you know. You know the food-wise. I went to Barbados and I had some grilled fish at time, boy. No comment. Yeah, well, Monique agrees. Monique agrees with that sentiment as well. Monique from Trinidad. Cool. Thanks, Leandra. Thanks for making sure that the classes, yes, so for students like yourself who might be quite familiar with your work and so on, um, I think the classes help for consolidation and repetition, yeah. So definitely, I think anyone can benefit. I honestly teach for weaker students. That's why I teach, right? Because I always say real bright students don't really need me. But the students who know their work well and they come, it kind of like just consolidates everything and makes the chances of distinction better. But I teach really for weaker students because who's gonna help the poor man out, you know? Um, let's see. Alexi?
Yeah, doc.
Yeah, what's up, bro? How things? I know you was the one who tell me to do this approach and try and make the easier class on you Monday. So I take your advice. How your class is going?
No, yeah, class is real good, doc. Yeah, one of the biggest things for me is that we started with IM and surgery, so like we forgot all those things. So it's good to like that's one of the biggest reasons why I'm doing the class to remind myself of all the content.
Okay. Thanks, man. Fantastic. Yeah, so Alexi wasn't going to do the course, then he decided to do the course, and then he wasn't going to do it again, then he decided to do it again. So I'm happy he joined, and he's been helping me out, like in terms of reviews and recommendations. I take everything you'll say seriously, and so I'm open to trying to adapt to facilitate, improvements. So thanks for that, Alexi, and definitely, man, remind yourself, yeah, remind yourself of all of the things, there's so much things you do in medicine and surgery, because I that was my rotation as well. When I started off year 5, I started off with internal medicine. So I mean, I was particularly
I like internal medicine the most, but to come back now before MBBS and study over everything, that was relics. That was pressure. But so thanks for that, Alex, and I think it will help in terms of review. Yeah, so let's see. And Ariel,
Hi, Doc.
hey Ariel. But sorry, yeah, I'll get. Yeah, Dan. Yes, Daniel also is one of my students who we always liaison and so. Thanks, Daniel. Good. Ariel from Mona, right?
Yeah, from Mona.
Yeah. How have the classes been for you?
Really good. Really
Yeah.
good. Yeah, you have a lot of valuable lessons. So I'm enjoying it and I'm learning a lot.
Okay. Thanks. Because it's really the Mona. Because I know my St. Augustine students and I know the KFL students. I never had Mona students before, so before offering it to you guys, I was like, should I offer it to them? Because I went to a couple Mona classes as a student and I was like, and them good, them set to go, them don't need me. But I'm happy that most of the Mona students, if not all of you, also have found benefits in it. And um, Ariel,
Yeah, I'm hearing you.
yeah. So what vacation spot you recommend in Jamaica? Because I hear it at the ghetto. I don't want to go to the ghetto. I want to go to the, you know, nice
Okay,
one.
I'd say Negril. I love Negril. The beaches there are really nice. And you could go to like the Rock House Hotel.
Like
Rock House.
Rock House Hotel in Negril.
Yep.
Okay, all right. So going with Ariel's recommendation. That seals it because I was looking for a place to go in. I never heard about it. I'm going to look into it. But if you say so, it's so. Good. And well, Jamaican music is my favorite type of music. Yeah, Ariel?
Somebody said I should recommend Denham Town. Really nice spot for vacation. And
Wait,
Tivoli
wait.
as well.
Okay. Yeah, I know
Yeah.
about Yeah, cool. Anton and Sydney seem to be pleased. Okay, all right. Okay, so we're not going to start the two fours here, right? We're not going to start the Cartel and Movado, Gully and Gaza Wars. We feel we know about them tunes down here. We well informed about all of these. Anyways, all right, guys. So thanks. You all keep me motivated and you all are very interactive. So thank you, all of you. I think I covered all the SCMR students. I'll get back to Miguel sometime when he chooses to answer me next time. Um, but I think I would have covered most of the Bahamas students if I haven't spoken to you all. All right. So thanks, everyone. Everyone seems to be enjoying the classes and so on. So that's good. So we're gonna get straight back into it. Miguel, last time I was calling you and you didn't respond, bro. That's why. But my time for talking is up. So Miguel, you'll be first. You'll be the first one to talk. And I was telling you thanks for all your assistance and everything. You probably didn't hear, man. But that's fine. But on Thursday, we starting off our chat with Miguel. All right, cool. So, TB, just reminding you of the questions. Which of the following is best suited for TB screening in a patient with the BCG vaccine? That's that. Um, we'll get back to this question where we had a lot of confusion for these two, 4 and 5. So that's good. We clarified that. And number 6, well, everyone would have obviously gotten number 6 correct, right? So number 4 and 5, we'll have to clear up in our teaching. But overall, TB is a gigantic topic. So let's get straight into it. I will be trying to do TB high yield in about 20 minutes. Guys, so tuberculosis is, as you can see, my guy, a huge topic. Please respect it. This is just the high yield stuff. All right. All of my lectures are high yield. Some things I do cover the entire topic, like literally, like. But TB, I can't cover the entire of TB, right? But I try to do all some justice here, and so we'll see the most high yield points, especially what MBBS has been bringing. So first thing about tuberculosis, let's just go back. Let's backtrack a little bit. Backtrack a little bit. So year 1 and year 2 stuff, just a little bit. I'm just gonna summarize briefly what happened. So this is somebody. Let's draw this guy here. Nose, a little smile there, and then nice good old TB come crawling, and it enters into his nose here, comes down the respiratory tract, right, and then comes here, and comes here, and let's say it goes in this lung, and it goes in this lung, And we call this is an X-ray view. So this is our right lung and this is our left lung. And we should know that our right lung has about like 3 lobes and our left lung only has 2, right? So tuberculosis is spread via respiratory droplets. So that's why he inhaled the tuberculosis and it went down into the lungs, right? Now, the first thing we're going to talk about is primary infection. So once this guy inhales this tuberculosis and it gets into the lungs, we're not going to go through all the macrophage engulfing it and interleukin 1, 6, and 12 being released, yada, yada. We don't talk about that. We're just talking about in primary TB, what's going to happen is this first thing is going to happen here. In some cases, I should put some cases, in most cases actually, in every case, in primary TB, you're going to have something here and you're going to have something here. So the first thing about primary TB I want you all to know is that this is primary TB, and that's primary infection with tuberculosis. That is not active tuberculosis just yet. This is primary tuberculosis when you first acquire the infection. So primary tuberculosis has different things that can happen. But in the primary infection of tuberculosis state, we have tuberculosis affecting the lower lobe is what I want to point out. And you have this thing called a gun focus, right? So a gun focus is basically your caseating granuloma kind of form surrounded by all of the macrophage and so on, right? So remember that in tuberculosis, we have a caseous necrosis, and it leads to initially in the primary infection, right? Not active TB, but in primary infection, we have a gun focus, and this gun focus can spread to the lymph nodes, and it leads to a hilar lymphadenopathy. And so this gun focus plus this hilar lymphadenopathy is called a gun complex. Okay? So the first thing I want you all to know about primary TB is that it affects the lower lobe, and you can see a gun complex, which is a hilar lymphadenopathy with a gun focus in the lower lobe. So that's primary TB there. Okay? Next, so this primary TB, this primary infection has a couple of things it can do. It can become latent, it can progress, it can heal, actually, and in some cases, it can disseminate, right? So primary TB, that's primary infection with TB, can heal, and it heals, and it clears. So we're done with that. If this primary TB, however, stays dormant in the body, it's called latent tuberculosis. And latent tuberculosis can remain latent, or it can become progressive tuberculosis. So latent is when it now goes in, the body contains the infection within that gun complex, within that granuloma form, and it's okay. Now, if this latent TB becomes reactivated, it is called secondary progressive tuberculosis because it was not activated and causing symptoms on initial infection. It went into the latent form, lay dormant in the body, and then reactivated. And in whom does latent TB reactivate? Immunocompromised. Okay, so patients with HIV, patients on immunosuppressants, patients with cancer, etc. So any cause of immunocompromise, of course, the big one we know would be our HIV patients. So that's where latent TB becomes secondary progressive. And it becomes secondary progressive usually in the setting of an acquired cause of immunocompromise. All right? So that's why HIV leads to secondary progressive. Whereas a primary progressive TB is when this primary infection immediately took the active TB form. And so that's primary progressive. So you have primary TB, but then you have primary progressive TB. Primary progressive TB is when you have active tuberculosis. You have primary TB that could become dormant and turn into latent TB, then reactivates and becomes secondary progressive. So the thing about progressive TB, it can be primary progressive or it can be secondary progressive, and that's the high yield teaching point there. Another high yield teaching point about progressive TB is that this is our active TB. And our active TB, this is our lung here, affects the upper lobe of the lung. Okay, so in our primary TB, the primary infection, we had the lower lobe being affected with our gun focus, gun complex hilar lymphadenopathy. But once that becomes active and it progresses, to active TB, whether it be through primary progression or it went to the latent and then secondary progressive stage, that infection now disseminates and it leads to upper lobe involvement. And the type of lesion here is fibrocavitary lesions. And fibrocavitary lesions in the upper lobe, once you see that in a question stem, that is tuberculosis in its active form. Okay, so that is particularly high yield. A little bit about the pathology. There's way more to it. There's how these things happen and macrophage and interleukins. But that, guys, is tuberculosis and how it happens in a nutshell. So that's what this picture goes on to show here. And you could read it on your own time and look through it, right? Good. So we said that the gun focus and the hilar lymphadenopathy gives us the gun complex, which is the hallmark of primary TB, and it is seen in the lower lobe, whereas primary progressive or secondary progressive are our fibrocavitary lesions in the upper lobe. All right, so that's that, a little bit about TB. Now, in terms of what MBBS has been testing, apart from pulmonary tuberculosis, remember that tuberculosis can become disseminated and it presents as systemic manifestations. So a pulmonary TB would be a fever, night sweats, weight loss, constitutional symptoms like cough, hemoptysis, and of course you have complications of tuberculosis, pleural effusion, bronchopneumonia, pneumothorax, etc. Pulmonary TB is bread and butter. I expect my year 5 students, anybody in medical school actually, to know how TB presents. All right. But the extrapulmonary manifestations of tuberculosis are particularly high yield, extremely high yield, so much so that this is really all they have been bringing thus far that I've seen was the extrapulmonary manifestations, the investigations, and 1 year they brought isoniazid as the drug of choice to test the side effects, right? So the most common ones that are tested would be TB meningitis, TB lymphadenitis, and POTS disease. Okay? So tuberculosis can infect the central nervous system and lead to a meningitis picture. And your tuberculous meningitis CSF fluid results, you need to know to interpret. It shows a lymphocytosis, even though it is Mycobacterium tuberculosis that causes the infection. But it shows a lymphocytosis and what we call an absolute lymphocytosis. What helps differentiate it from our viral meningitis would be in viral meningitis, we usually have a normal glucose and a slightly to normal normal to slightly elevated protein in viral meningitis. In tuberculous meningitis, along with a lymphocytosis, you have an elevated protein but a low CSF to serum glucose ratio. So when you get your CSF lab results, know how to differentiate between TB meningitis versus viral meningitis, as well bacterial meningitis being the easiest to low glucose. But your white cells would not be lymphocytes, it will be polymorphonuclei or neutrophils. All right. So let's remember these findings for your tuberculous meningitis. So that's one. The other thing is this picture that they brought last year, June, no, last year December, no, last year June, of this patient with this little swelling here in a tuberculosis patient, right? So it was TB cervical lymphadenitis, and the other name for that is a scrofula. Okay, so TB can spread and affect the lymphatic system as well. TB can affect the heart and lead to pericarditis. We went through that already. Can affect the liver and lead to hepatitis. Can affect the bones and lead to osteomyelitis, and it could have tuberculosis disseminating, miliary TB especially disseminating and causing Addison's disease when it spreads to the adrenal gland. This is mainly seen in miliary tuberculosis. This adrenal gland is seen mostly in miliary tuberculosis. But the other two that they like to test, guys, would be tuberculosis involving kidneys and causing a sterile pyuria. Can anyone tell me what sterile pyuria means? Already? Okay. So sterile pyorrhea is where you have fantastic, Brianna. Yeah. So it's where you have increased white cells in your urine, but you don't have bacteria significant enough to say it's a bacteriuria. So how many colony forming units gives you significant bacteria in our average patient, a regular patient, from a ordinary midstream urine sample? What number of colony forming units is significant, guys? As a hard question, or like 10 to the power 5? You know that? Right? 100,000. Good. So 10 to the power 5 colony forming units, that suggests significant bacteria, and therefore that's how you really diagnose a true urinary tract infection. For simplicity's sake, right? So in a regular patient, if they have increased white cells in the urine, you expect there to be significant bacteria, suggestive or suggested by more than 10 to the 5 colony forming units on your culture, right? But in the case of tuberculosis, they have increased white cells in their urine, but we don't see any organism. And that's also seen in sexually transmitted infections. A lot of STIs, if not all, they give you a sterile pyorrhea. And so that's why you cannot detect an STI based on a dipstick. You need special tests when you do STD testing. If you are to give a urine sample for, say, chlamydia or gonorrhea, you don't dipstick it. You do things like PCR, etc. All right. So tuberculous involvement of the kidneys can lead to a sterile pyorrhea, and that is particularly high yield. Last extrapulmonary tuberculosis manifestation that is particularly high yield, guys, is Pott's disease. Pott's disease is back pain in tuberculosis. All right. So this is where the tuberculosis affects the spinal vertebra, and so it gives this kind of image here, and that's called Pott's disease. Patient, give you a X-ray. This patient looking like they have tuberculosis, and then the back kind of hunched like this. Just think Pott's disease. All right. You could read up a little bit more about Pott's disease, but it's just one of those pattern recognition questions in patients with TB. Back pain and TB, Pott's disease. Right. So that's that. So these are the extrapulmonary manifestations that are highly tested, and that is sufficient for your exams. Good. Now would be the diagnostics of tuberculosis. So guys, when it comes to working up patients for TB, we have to think first about screening patients for TB and then confirming the diagnosis. So there are two main tests that are used for screening of tuberculosis. One is the MAN2 skin test, as we know. Also the purified protein derivative, your tuberculin skin test, all these ways that they name the test, right? Know the various ways in which they name it. It's the same thing. Sometimes you'll just see purified protein derivative, PPD. That's a tuberculin skin test, right? That's a MAN2. It means the same thing. Okay. Now, when you do a MAN2 test, what is the route of administration? Where do you inject the purified protein derivative? Can anyone tell me? No one? Well, quiet boy. Okay, so Leandra says subcutaneous. Thank you for that, Leandra, because it is actually not, right? So it is intradermal. Thank you, right? So it's intradermal is the answer to that question if it ever pops up. Now, when you do an intradermal tuberculin skin test, skin intradermal, right? The interpretation of the tuberculin skin test varies based on who is affected or who gives a positive purified protein derivative. The end duration is what we measure, not the redness. Okay, guys? So it is the swelling of the skin. And so in those patients who are extremely high risk, their threshold for a positive tuberculin skin test is reduced. So if you have an end duration of more than 5 millimeters in an extremely high risk patient, that's a positive MAN2. If we have a positive MAN2 in a patient, if you have a more than 10 millimeters, sorry, in a patient who is high risk of exposure rather than just high risk of active TB, that's positive MAN2. And in everyone else, anybody with a MAN2 that gives an innovation of more than 15 millimeters, that's a positive MAN2. So immunosuppressed HIV patients who have relatives and living at home with patients with active tuberculosis, or if you have a high clinical suspicion, meaning that they have classical fever, cough, hemoptysis, yada, and you're thinking, all right, this patient likely has tuberculosis, then more than 5 millimeters in duration is a positive MAN2 in them. Patients like us, healthcare workers, immigrants, and so on, we are at moderate risk. And so our threshold is actually lower for a positive MAN2 as well. So if someone like you, a medical student who's always on the wards, has a MAN2 more than 10 millimeters, I will say that is a positive screening test, a positive MAN2. And in the average person, no real risk increase, more than 15 millimeters, that gives a positive MAN2 as well. That's important to know these values, guys. The other important thing to know about screening for TB is when you're going to actually say, all right, MAN2 is really the easiest one to do, but it's not preferred. In whom is interferon gamma release assay or quantiferon gold particularly preferred? That is beta HCG vaccine patients. Why? If they have the beta HCG vaccine, a MAN2 says that you had exposure to the tuberculosis, to the tuberculin skin test. And therefore, you will get a false positive if you give them a MAN2. So in patients with the beta AC, with the beta ACD, with the beta BCG, oh guys, you'll correct that in the guide, right? I can't edit this thing. So in the BCG vaccine, I'm saying beta HCG there. And the BCG vaccine, whatever that long BCG word stands for, those patients, we do interferon gamma release assay. Okay? So BCG vaccine, IGRA. All right? So that's a particularly high yield point as well. Patients who are at higher risk, like HIV sarcoidosis, because sarcoidosis presents with a bilateral lymphadenopathy, it can present with fever and a cough as well. You might think, all right, this is probably TB, this is probably sarcoidosis, you're not sure. Sarcoidosis, if you're thinking TB, you want to do a IGRA as well. Okay? Other than that, either one is fine. Academically, this is the concepts that they test, right? IGRA is preferred in patients with the BCG vaccine because a tuberculin skin test would give you a false positive. So once you screen, you get a positive skin test, you get a positive IGRA, that's just screening. Most of the times, we'll get a positive skin test. Now, a positive MAN2 does not mean active or latent. It just means exposure to tuberculosis. So if you have a positive MAN2, you have to do two things. You need to get a chest x-ray, and your chest x-ray may show either the latent TB, which would show your gun complex, right, at the lower lobe with some hilar lymphadenopathy, or active TB, which would show our fibrocavitary lesions at the upper lobes. And that's why I spoke about the chest x-ray findings earlier on. But once we get a positive MAN2, guys, we must confirm our diagnosis. And the gold standard diagnostic test that MBBS loves to bring is very easy. It's an induced sputum for acid-fast bacillus, smear, and culture. And the stain that we use, if you remember from microB, is a Ziel-Neeson staining. And the culture medium we use is a Lowenstein-Jensen medium, right? So induced sputum, that is, we give them some nebulized saline and then some sputum, 3 samples, 8 hours apart. Usually we'd actually do early morning samples on the wards. And therefore, once we do that, we go and we test for acid-fast bacillus. That's positive for tuberculosis. Then we say this is active tuberculosis. All right. So it goes screening. We suspect a patient with TB. The first thing that we'll do, we're not going to do sputum right away. First thing we'll do is, all right, we think in TB, we could either do a tuberculin skin test, which is easiest, or IGRA, depending on the patient's vaccine status and so on. Most of the times we'll do a MAN2. Once the MAN2 comes back positive, we do a chest x-ray, but we also have to do induced sputum for acid-fast bacillus, smear, and culture. All right. And once that's positive, that's when we say this is active tuberculosis. Right. The chest X-ray can clue us into latent TB based on if we see our gun complex and so on. Good. The other test that pops up for tuberculosis is the test of choice to detect drug resistance. And please take note of this. The nucleic acid amplification test is test of choice to detect drug resistance. All right? Please take note of that. We have multi-drug resistant TB as a topic, but I don't teach that because I've never seen MBBS bring it. You could read up a little bit about multi-drug resistant TB. Right? I've never ever seen a question on it, but read up a little bit about multi-drug resistant TB. Good. So we have some cavitary lesions here. So this is fibrocavitary. This is active TB for sure. Still have a little hyaline-lymphadenopathy, so on. That's that. Something I was going to tell you all. Oh my gosh. Oh my goodness. Damn. Brain fog. Sorry about that, guys. Something I was going to tell you here, and I forgot. If it comes back to me, I'll remember, right? So anyways, guys. So screening test for TB, man 2. IGRA preferred in BCG vaccine, do a chest X-ray, gold standard, sputum, induce sputum for acid-fast bacillus, right? And we have to induce the sputum using nebulized saline. The last thing about tuberculosis that they test is the treatment. The treatment of tuberculosis depends on if it's active or if it's latent. We do not treat latent tuberculosis like we would treat active tuberculosis. And so, guys, this thing here, 2 ripe mango plus 4 eyes, for the life of me, I will always confuse the active TB regimen and put 4 ripe and then 2. I couldn't remember. So this is my way of remembering it. You're given 2 months of ripe rifampicin, isoniazid, pyrazinamide, and isambutol, plus 4 months of rye, rifampicin, and isoniazid. So I remember it as 2 ripe mango plus 4 eyes. Okay, so that's how I remember it. It works for me. I don't confuse it anymore simply because of this. I used to confuse it all the time as a student. So if you're like me, this could probably help, right? So it's 2 months of rifampicin, isoniazid, pyrazinamide, ethambutol, and 4 months of rifampicin and isoniazid. That is the treatment, gold standard, up-to-date treatment for active tuberculosis in a non-drug resistant patient, of course. So you need to know everything about all of the tuberculosis drugs. Everything, mainly side effects, but you should know a little bit more than just side effects for all medications. But what they test in TB is just the side effects of the drugs most times. Rifampicin, R for rifampicin, R for red-orange discoloration. Very easy, right? So red-orange discoloration of bodily fluids, patient peeing red, they have red tears, they have red sweat, that's rifampicin, all right? It can cause, they're extremely hepatotoxic, as most of these TB drugs are. They can cause thrombocytopenia and other things as well, but that's the most common classical side effect. Isoniazid is the one that they bring. Usually they bring it as peripheral neuropathy, and it is due not to B12 deficiency, but due to vitamin B6 deficiency. That is pyridoxine deficiency. Isoniazid can cause a sideroblastic anemia as well. And when we get to rheumatology, we'll see all the causes of drug-induced SLE. Can anyone tell me what is the antibody of choice to detect drug-induced systemic lupus erythematosus? Antihistone. Fantastic, Selena Melina, right? Whereas the most specific is what? For just regular good old SLE? The most specific antibody? Fantastic, right? So for drug